This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 79 for August 17th, 2022. We're calling this one Pediatric Pain from the Family Perspective. I want to welcome all of you to the program. And that welcome, by the way, is extended, of course, to our regular PediaCast CME listeners, but also listeners of other podcasts who might be checking PediaCast CME out for the very first time. Because today's episode, of course, stands on its own, but it is also part of a series on pediatric pain. And it's a series that incorporates content from several different pediatric and emergency medicine podcasts. So each episode stands alone in its home podcast, but together they form a unique and hopefully helpful series on pediatric pain. And I'm going to put a link to the series in the show notes for those of you who were not aware of this bigger picture. It turns out this particular episode of PediaCast CME is a co-production from Nationwide Children's Hospital and the Emergency Medical Services for Children Innovation and Improvement Center, whose mission is to minimize morbidity and mortality of acutely ill and injured children across the emergency continuum. And to learn more about the Emergency Medical Services for Children's Innovation and Improvement Center, you can visit their website at emscimprovement.center. And I'll also include a link to that site in the show notes for this episode, number 79, over at PediaCastCME.org. So right out of the gate, the show notes are going to be particularly helpful for you this week as we consider pediatric pain and anxiety from the family perspective. To help us explore the topic, we have two terrific guests joining us in the studio. Dr. DJ Scherzer is a pediatric emergency medicine physician at Nationwide Children's Hospital, and Courtney Hall is a child life specialist at Nationwide Children's. Before we get to them, I do want to remind you, you can find our podcast, PediaCast CME, wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. And also, please consider leaving a review wherever you listen to podcasts so that others who come along looking for free continuing medical education credit will know what to expect. Speaking of that education credit, it's really easy to claim yours. Simply listen to the podcast, which you are about to do, and then head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. It's completely free. And we offer credit to many pediatric professionals, of course, including doctors, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by many professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice, which in this particular case, it's going to match pretty much everyone's scope of practice because in one way or another, we all deal with families and patients who are impacted by pain in the pediatric population. Complete details on the CME part of this is available over at PediaCastCME.org. We're also on social media. We love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. And we have a contact link over at PediaCastCME.org as well if you would like to suggest a future topic for the program. Also want to remind you the information presented in our podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals individuals. Our discussions may contain only a portion of relevant information and should not be solely relied upon for the diagnosis or treatment of any medical condition. We do not cover every possible treatment options, and the treatment options we do cover do not include every possible use, precaution, side effect, or interaction. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get Dr. DJ Scherzer and Courtney Hall settled into the studio, and then we will be back to talk about pediatric pain from the family perspective. It's coming up right after this. Dr. DJ Scherzer is a pediatric emergency medicine physician at Nationwide Children's Hospital and a professor of clinical pediatrics at The Ohio State University College of Medicine. Courtney Hall is a child life specialist at Nationwide Children's. Both have a passion for helping kids and families feel better in our emergency department. Feel better from pain, yes, but also anxiety, because these two things often travel together. Pain amplifies anxiety, and anxiety augments pain. So you really have to deal with both issues and consider the context of the family in order to make a big difference for little patients. That's what they're here to talk about, pediatric pain, and in particular, pain as it relates to anxiety and within the context of a child's family. So let's give a warm PediaCast welcome to our guests, Dr. DJ Scherzer and Courtney Hall. Thank you both so much for stopping by today.
Thanks, Mike.
Thanks for having us.
Yeah, really appreciate both of you taking time out of your day. So let's start with you, DJ. What, just kind of remind us what causes pain. We have a medical audience that's the primary audience. So, of course, most of them are going to understand that. But we also have some parents who listen to this podcast, and just kind of explain from a physiology standpoint, what is pain?
Yeah, so today we're going to be talking about pain as a response to acute injury or injury related to procedures. And so our body recognizes when something's not supposed to be happening. And so there's a signal that occurs at the site of the injury. It starts there, it goes to our brain, and then our brain makes us feel the pain at the site of the injury. So it's something that's happening in our head, but we experience it as a signal at the site of the injury.
Yeah.
Teaches us not to do that again.
Yeah, absolutely. And kind of lets the brain know something's wrong. There's something going on that shouldn't be going on, whether that be temperature feelings like with burns, or whether it be pressure, pain, all those things. It's just a defense mechanism, really.
Correct.
Yeah.
Yes.
And so as we think about the fact that something is happening at the site of the pain, however, there's also something happening in the brain, there's sort of an objective and subjective component to pain. Objective in terms of just the stimulus causing neural impulses to go to the brain, but then we subjectively experience that pain in our head in response to those signals, correct?
Yeah, what we're calling subjective is all the context that impacts how we experience it. So two kids can have the same broken arm, go through the same procedure, but have a different experience.
Yeah. And as I mentioned in the introduction, one of the things that impacts that experience is other things happening in the brain, like anxiety, which happens a lot when kids are injured. They're in the emergency department. There's a lot of unknown and strangers doing things that might make it more painful. So talk a little bit about how that makes a difference, the anxiety piece of it.
Yeah, we try to be sensitive to that. And one of the things that we know from emergency medicine and also from other fields is that previous pain experiences can impact future pain experiences. And we know that anxiety and pain are intertwined because we have these mechanisms to feel pain and to feel anxiety for the same reason. They're self-protective and they're defensive. So they're naturally intertwined with each other.
Yeah, absolutely. And if there are things that can make pain worse in the head, things like anxiety, past experiences, the context of what's happening here and now, it would make sense that there are also some things in the brain that we can do to improve the experience, correct? Other than just treating the pain itself, there are other things we can do from a mindfulness perspective to make a difference.
Yeah, there are components of the whole experience that are malleable, intrinsically malleable, and also things that we can do to make life easier for the person who's going through it, both pharmaceutically and non-pharmaceutically.
Yeah. What are some examples of that from a pharmaceutical and non-pharmaceutical? Like what when the rubber hits the road, what can we do to help kids not have as much pain?
So non-pharmaceutically or non-pharmacologically is imparting confidence, letting the family and the child as a unit, letting them know that we're here for them, we're going to be paying attention to them, and that they're in good hands and that things are going to work out well. So that helps. And then we have a small armamentarium of pharmacological things that we can do.
Yeah, absolutely. And those can range from oral medications to IV medications and lots of different
intranasal medications, which is one of our new favorites.
Yeah, because we get it in quickly and it helps quite a bit in the acute setting in the emergency department.
It gets absorbed well.
Yes, exactly. And I want to pause here to make what I think is an important point, because we're talking about pain sort of from the family perspective. And it's interesting because from a medical provider's point of view, a person is there and they're having pain because of some injury or some illness, whether that's abdominal pain or whether it's pain from a broken bone. And our primary the primary focus that we have is on figuring out what's wrong and what to do about what's wrong. So we want to fix the fracture, reduce, if it's angulated and all that. We want to find out what's causing the abdominal pain. Is it appendicitis? Is it something else? But the family's focus is really more on my kid's in pain and I want that pain to go away. And the kid is like, I'm in pain. Can you help me help the pain go away? And so sometimes there's a mismatch on priorities. And so it really behooves us as providers to understand that this is something that may not be important to us on the top of our mind, but it's incredibly important to the family.
Yes. And that's why communicating is so important. Getting a feel either from them directly telling you or just kind of your sense of it, of what they're going through. Sometimes acknowledging our own tendency towards stoicism. We tend to be a little bit that way. And of course, it's always easier to tolerate someone else's pain. So we try to be sensitive to what they're going through.
Yeah.
And make them aware that we're trying to do that.
Yeah, absolutely. I feel like you can also over-respond to that to some degree. And historically, I feel, especially in the adult world, that we've gotten into trouble as pain became sort of thought of as a vital sign and being able to measure the pain because that was tied into patient satisfaction. And we know satisfaction scores can impact like Medicare and Medicaid payments. And so that all becomes very complicated and really, I think, and I think others think so too, fed into the creation of the opioid crisis. And so it's really, it's a road that you have to travel to make kids feel better, make families feel better, but also understand that, especially as we talk about chronic pain control, we can get ourselves into trouble if we're just prescribing opioids, right?
Yeah, that's the natural pendulum of things. We address a problem, and then we manage to create a new problem for us to try to solve.
Yeah, absolutely. So something to keep in mind as we walk that path in helping families deal with pain. Before we get to Courtney, our child life specialist, one other thing I wanted to mention, even though pain is not necessarily at the top of our priority list, sometimes, especially as we're trying to treat an acute injury or illness, pain does impact the medical team in terms of our exam. Talk a little bit about that.
Yeah. So, one, in terms of pain as a priority, I think over the years we've gotten better at prioritizing it, because ultimately it's about an experience. We want the patient and the family to have a good experience. And yes, addressing pain, addressing symptoms in general can help improve the accuracy of an exam. For instance, Slightly off topic, an infant with a fever can look kind of maybe not so great while the fever is there, but we get the fever down, and then looking at that delta, what did they look like 45 minutes ago, what do they look like now, can be informative. Same thing with pain. Someone can have a lot of pain. It doesn't necessarily tell you a lot about what's going on in the inside. We've had kids with constipation who are doubled over. We've had kids with appendicitis who are cool as cucumbers. So trying to level the playing field in terms of pain can also help us with an assessment.
Yeah, definitely. We want to partner with parents in the room. And if the parent gets the impression that we don't care if their child is in pain or not, that we're really focused on diagnosis and management of the acute problem, that's going to interfere with our ability to communicate effectively with the parent. And so that's another reason that it's important to deal with this so-called elephant in the room.
Yeah, it's a great point, because there has to be mutual trust.
Yeah.
And a sense of a connection there. For everything to work.
Yeah, absolutely. I mentioned that we have Courtney Hall with us today, and she is a child life specialist. I want to just start out with what exactly is a child life specialist, and in particular, what's your role in the emergency department?
Sure. So child life specialists are formally educated and clinically trained healthcare professionals who are on the psychosocial side of things, and our job is really focused on promoting patient and family-centered care, helping patients, families, siblings, even other children who may have been involved at the scene or involved in their lives, cope with medical encounters, diagnoses, bereavement, loss, change. Any of those types of things kind of falls under our umbrella. So in the emergency department, a lot of our interventions, of course, are geared at providing education about what's going on, what to expect while you're here, but helping them cope with sometimes the really scary events that happened that led to them coming to the hospital, sometimes the scary events that happened while they were at the hospital. So we're really focused on that acute anxiety management, especially in an emergency department setting. It'll look different depending on the unit and the needs of those patients.
Yeah, absolutely. I would suspect that in the emergency department setting, you probably are dealing with acute pain and families that are experiencing that pain. And of course, they're having empathy for their child who's in pain. And so that really does take up a lot of your time. Whereas on the units, I mean, there may be more education about a chronic disease, making sure that kids are getting playtime and that their siblings, are also looked after and those kind of things.
Yep, making sure everyone in the family is able to be involved in an appropriate way that helps them be able to kind of transition right back into their normal day-to-day after they leave the hospital in an effective way.
Yeah. And that's going to also differ depending on the age of the child and their developmental level and how they respond to pain. I mean, some kids, it's going to be crying and complaining about the pain, but for other kids, it may be getting grumpy toward your family and acting out toward the medical team. And so being able to figure out, what's really causing behavioral issues does come down to understanding child development and how kids respond to pain at different ages. So I would suspect that you need to know a little something about child development. So talk a little about the training for child life specialists if someone wanted to pursue that as a career.
Sure. So child life specialists come from a range of backgrounds, but at the very core of it, there's requirement to have a minimum of a bachelor's degree. Typically, that is either in child life or a closely related field, but it requires specific coursework to be included in that. And once you have met all of the requirements to be able to enter a clinical setting, you complete usually a practicum before an internship, but at least an internship that's 600 hours, and then sit for a certification exam, and then certifications maintained through continued education or retaking the exam every 5 years.
Yeah. And I would suspect you have no regrets following this career path. This is something that you're really passionate about and would encourage folks to look into as a job.
Absolutely. It was something that I discovered kind of later on in my college career and was like, what? I didn't know that existed. So I absolutely encourage people who have a passion for working for kids, have a passion for working in healthcare settings, to look into that role and see if it's a right fit for you, because it's a really rewarding job and one that I would have been upset if I found out later in life about and didn't have the opportunity to jump into.
Yeah. Yeah, that's fantastic. I'm going to put a link in the show notes to the Association of Child Life Professionals, and there's lots of great information at that site about the profession. So if there are folks who are interested, or you have a child who you think might be interested in this as a career, you can find out lots more about child life specialists. And again, we'll put that in the show notes over at PediaCastCME.org for episode 79. So DJ and I, we look at pain from the perspective of the treating provider, and how is this pain impacting the disease and our ability to relate to the patient. But there's really lots of ways that pain impacts young patients and their families beyond just kind of what we see. But if you look at the whole person, what are some of those ways that pain impacts kids and their families?
Sure. So pain, just like DJ had touched on earlier, is very subjective to previous experiences. So if a child has had negative experiences with unmanaged pain is going to be something that's really scary, and they're not going to have a whole lot of self-efficacy in their ability to cope with and deal with. So when we're looking at families and kids coming in experiencing this pain, their stress level is pretty high. We can see it in the way they're interacting with each other. They're kind of out of their comfort zone. So we see a lot of parents feeling like, I'm usually able to calm my kid down when they're upset, and nothing I'm doing right now is working, or I am very scared about their safety. So I'm not super, worried about their pain, but I know my child is, but I just want to know, are they going to be safe and okay and make it out of here? So there's a whole lot of factors that are thrown into kids' brains and parents' brains when they're experiencing pain. And it can be really difficult too for parents to figure out, which side of that do I prioritize? Do I prioritize trying to calm them down, or do I need to be asking the doctors questions and understanding from the medical professionals what's going on? So as a child life specialist, our job is to really jump in and kind of help facilitate coping strategies that are typically already in place. A lot of these families have protective factors, have strengths. We are trying to help them identify those in a chaotic environment where it's hard to see.
Yeah. I mean, because as a parent, if you're at home and your child's upset, you sort of naturally know what is going to make them feel better. But then when you're experiencing the stress of an emergency department yourself, you may not immediately think of the things you would normally think of at home. And so you can sort of remind them, hey, what is your child like? Would they want the TV on? Do they not want the TV on? Would they rather have a toy, not have a toy? Just to kind of, really collaborate with the family on what the best practices are for that particular child.
Exactly. We are experts in development and helping kids cope. They are experts on their child. So we partner with them of, here's what generally works for a lot of kids this age going through something like this. Tell me what you think is going to help your kid cope, and we'll start from there.
Yeah. And then you also play a role in education for particular things, because you see a lot of the same things over and over and over again, and you may be able to predict what a family may be, if they were in the right mind to ask the right questions, what they would want to know the answers to, but they may not be thinking of that immediately. But because you've worked with so many other parents whose child has had a broken bone and needs to have a reduction and a cast and perhaps a sedation, you sort of can predict what the parents would want to know. And there's a real educational piece to that.
Sure. Yeah. So, of course, within our scope are providing education about what to expect from the child's responses, from what a parent involvement can look like. So if that's during a procedure, or we're placing an IV so that they can get a medicine to be sedated for a reduction, we're providing a lot of anticipatory guidance surrounding more of how they're going to respond and what is appropriate to do. So some parents don't realize they can be right up there at bedside. You can hold your kid's hand, you can rub their head. So it's a lot of kind of just reminding them where their role can be and empowering them to do that, but also acknowledging that that's not always where parents feel most comfortable or where the kid wants a parent to be. So also just really working with families to figure out, what information do you feel like you need, or what do you need us to pick up on?
Yeah. And from a practical standpoint, you also provide toys and things to distract them, right? I mean, there's a lot of fun stuff that, I walk in and like, I think, did you bring this from home? No, Child Life brought it.
Sure. Yeah. So normalizing the environment, taking the threat out of the environment is a really important step from a child life perspective of helping a family cope. So when they're in that acute stress response, they're in that fight or flight stage, when they're looking around and they see a bunch of stuff that they've never seen before in the room and they don't know how to interact with, and it looks like it might be able to hurt me or it looks scary, it gives them less things to kind of ground themselves on. So when we can give them a developmentally appropriate item that is familiar, something they know how to engage with, we're giving their mind a little bit of respite of having to be acutely focused on the environment, but rather, I know what this toy is, I know how to interact with it, and it kind of gives them that sense of control.
Yeah. What are some of your favorite items that you provide to kids and families within the context of the emergency department?
So obviously it's a fast-paced environment, a lot of turnover. So we don't have all the things inpatient has for providing to kids. So a lot of our stuff is kind of like give and go items. So Play-Doh's a big one. Of course, we need it to be given to developmentally appropriate ages, or some kids are prone to eating Play-Doh. And so if they're MPO, like that's also a factor that I'm talking to families about, like, do you think this would be appropriate based on things? But Play-Doh's a huge one. It's something a lot of kids know how to interact with. It's something that they can use their imagination with. It's also a coping tool. You know, we can use it as something to, can you squeeze this and feel it squishing through your fingers and kind of do that diversionary engagement during uncomfortable parts. So Play-Doh, coloring, stuffed animals. We use stuffed animals a lot too for just modeling what we're going to do on their body to a stuffed animal. So maybe it's really scary because they're going to come listen to your lungs and heart with the stethoscope. But once I saw that, do that on the stuffed animal, I remember what that is. And it takes some of that fear out. So we're doing medical play and bringing medical play kits into a room, and also helping kids feel empowered that you could do the blood pressure cuff on your stuffed animal or the arm hug that we call it. So it's a lot of play resources that are tied to coping with medical encounters.
Yeah. And that must really not only be great for the kids, but for the family too. I mean, because they have those same questions. They wonder what's going to happen to their child. So being able to model that on the stuffed animal, I'm sure that also gives a lot of parents some reassurance too.
Absolutely. I'll find parents saying, I didn't even realize that, if we're doing a prep for an IV and they think the needle remains in the catheter the whole time, and I'm able to show them that it's flexible and bendy, and parents are in the background saying, oh my, seriously? Is that actually how it works? Like, they don't know if I'm messing with the kid to try to get them to be compliant for the procedure. And is surprising sometimes to figure out how much is common knowledge to us because we're in the setting every day in and out, but is not even to adults who are high functioning, well-educated. So it's absolutely learning opportunities for everyone.
Really great points. I am wondering, a lot of kids, particularly younger kids, can really take some warming up before they're willing to engage with you. What are some things that you do to maybe help that occur a little bit faster? Because you're still a stranger to them, and they may not even want to look at you. Absolutely.
So first and foremost, I'm looking at my body language when I walk in the room. Am I standing over the bed? Am I hovering over them? Or did I let them kind of warm up to me first by the doorway when I came in and introduced myself, that I didn't necessarily directly approach the patient with my hands out because I'm ready to touch them. So there are some things like that where I'm even showing with my body that first I'm introducing myself at the doorway. If I'm getting closer to the bedside, I am crouched or identifying what I'm doing of I'm coming to talk to mom or dad, or I'm coming to show you this toy, or I'm coming to listen to your heart, whatever that may be, really identifying first what you're doing and why. But then if there's a kid who's not warming up to you in that way, trying to engage with them about something typical or normal in their lives. So asking if they have any pets at home, or a brother or sister, or what their favorite show on Disney is. Or I know a lot of staff in children's hospitals wear things on their badge that can kind of be like a quick rapport builder. So even having a pop-it coping item that I'm able to have on my badge and say, do you know what this is and how to work it? And it kind of gives them that sense, like, oh yeah, I know what that is. And I'm willing to talk to you about that thing because it's not the scary thing. So whether that be, here's what we're going to do, or first let you warm up to me and tell me a little bit about anything outside of the hospital and why you're here today can be really helpful.
And that's really great advice for the clinical providers as well. If you have a kid who's not engaging with you, asking them those questions. I know before I do a sedation, a lot of times I'm talking to the kid about that very thing. Like, what animals do you have at home? What do you want to dream about while the sedation is happening? And those kind of things. So it can definitely make a difference.
Sure. And sometimes building that rapport and trust is also acknowledging if they're asking a question or I'm scared and I don't want to be here, instead of saying, well, what's your favorite animal? 'Cause sometimes that can be helpful, but that can also communicate to a kid, like, I'm not really concerned about the same things you're concerned about. So building rapport can also just be giving that space for them to share what they're worried about and showing I'm listening and I understand that that's a concern and we are here to address all of your concerns.
Yeah. If you're trying to talk to them about their pets at home and they keep asking you, is this going to hurt? Is this, then it's time to adjust that conversation a little bit.
Absolutely.
Yeah. DJ, I want to talk a little bit about the pain medications that we use. Not necessarily from a clinical perspective, because I think a lot of our audience already knows what's available and how it works and that sort of thing, what the risks and benefits are. But from the family's perspective, as you're sort of giving options or sort of guiding families on what we ought to be giving their kids, like how do you approach explaining the medication piece of it to them?
Yeah, a couple of things. First, I just wanted to add something to what Courtney said. Probably less than 4% of the emergency departments in this country are pediatric. So we're very accustomed to having little kids sit on mom's lap or having the family stay in the room for as long as logistically feasible. So we do that. And in terms of talking to medications, talking about medications with families, a concern that comes up is actually stuff that segues off of the news. How dangerous are these medications? Sometimes people hear the word fentanyl. And we reassure and put in context that this is medically appropriate. It's indicated. Our sources are clean and pure, and we're using dose appropriate and indication appropriate doses in a time limited way and in the right setting. So, and often that's usually what people just need to hear.
Yeah. I have found that just within the last few years with intranasal fentanyl, because we love using that when kids are really in acute pain. As we mentioned before, it gets absorbed so quickly and makes a difference even before someone has an IV in. But yeah, when families hear that word fentanyl, you always get a double take and have to explain this is not street fentanyl that we're talking about.
Yeah, exactly. And Versed sounds a little bit more benign, though people don't always know what that is. But I usually tell them it's like a short-acting Valium, and people get that.
Yeah, absolutely. Another little trick that I have found over the years that works pretty well is if especially if parents are hesitant for opioids in the acute emergency department setting, or and especially as we're discharging them home, is the use of acetaminophen and ibuprofen together at the same time. And there was actually a study done with the hand folks at Ohio State where they had adult patients who had surgery plates put on because they had broken wrists. And one group, they gave an opioid pain medicine for post-surgical treatment. And the other group, they gave acetaminophen and ibuprofen together every 6 hours, and then, did
pain scoring or pain assessment. Yeah.
Pain scoring, pain assessment. Yeah, exactly. And they found that the acetaminophen ibuprofen group actually had better pain control than the opioid group. So that's a story, because a lot of parents will be like, wait, I can give acetaminophen and ibuprofen at the same time, but they actually are synergistic and help each other work a little better.
Yeah, there's actually been a number of studies like that, kind of demonstrating that just plain old acetaminophen and plain old ibuprofen are at least as good as opioid-based medications. And there are a couple of myths to get over with that. One as well, it's just ibuprofen, it's just acetaminophen. One, you can combine the two. Two, you're also combining the medications with other non-pharmacological things. Like, for instance, if someone has had a fracture and is reduced and they're casted and supported and immobilized, that in and of itself helps control pain. Plus, you talk about elevation and the use of ice, things like that. The other thing that's really common out there, and it may sound kind of petty, but people underdose ibuprofen and acetaminophen. And the labeling out there is ultra conservative. Because the companies, the manufacturers, the distributors, they have to be careful about what they put on paper. But in reality, there is room to liberalize that dosing. And if you don't talk about it and spell it out for people, people may not know. or if they go to the web and look at labels and tables and obvious public-facing stuff, they're going to end up lowballing the dosing. And so there is room to maneuver that's quite safe and makes these medications more effective.
Yeah. And I think it's easy to pass up that kind of education because you just think, well, everybody understands, they probably have it at home already. They don't need to know anything about it, and there's dosing on the labels. But when we really make an effort to use weight appropriate doses for a particular kid, we can say to the parents, we can ask, how much have you been using, and then educate them that it's safe and okay to use a little more than that.
Yeah. And so not only do labels and tables and packaging instructions tend to underdose, but they're hard to read anyway. I mean, even our own discharge instructions, there's an option to say, follow package instructions. Well, have you tried to read package instructions recently? You have to have pretty good eyesight. You have to know where to look for. And you have to be patient. It's kind of hard to find.
Yeah, absolutely. And then the other important thing is to recognize that there may be different concentrations. It was terrible when there was more than one for Tylenol or acetaminophen. Right. And they got rid of the infant one, although it'll still say infant because that one comes with a syringe instead of a cup.
Yeah.
So they still have infant and child, but at least the concentration of the medicine is the same. But ibuprofen, I think there's still 2 concentrations out there.
Yeah, the infant one is actually twice as concentrated. And one of the things that I have no qualms about telling people is that the infant products are just a marketing ploy. Just get the children's stuff. It's you not only get more medicine for your money, but it's also the instructions are easier.
Yeah.
Easier to read, and it's actually safer.
Yeah. I also want to point out, since this is a medical audience, and this is something I talk to residents and even new nurses a lot, and I'm always surprised that people don't know this. You ever wonder why acetaminophen is 160 milligrams in 5 milliliters and ibuprofen's 100 milligrams in 5 milliliters? And the reason is so that a 10 kilogram kid can get 5 mLs or a teaspoon. And so back when you and I were practicing before there was an electronic medical record and we had to do everything by hand and calculate in our head, it made it easy that 1 teaspoon for every 10 kilos until you got to the adult dose was pretty standard for most medications, including acetaminophen and ibuprofen. So if you take a child's weight in kilograms and divide that by 2, that's how many milliliters of the medicine that they need. And so it's always a neat trick, like, oh yeah, this is off the top of my head, this kiddo needs 8 milliliters. But that's the kind of the history of it and why the concentration is what it is.
That's a great point. Acetaminophen is 16 mgs per kilo. The computer sometimes changes that to 15 mgs per kilo. Just think of it in terms of 16 mgs per kilo. Ibuprofen, 10 mgs per kilo. That means it's 5 mLs for every 10 kilograms. Or if you're into pounds, you could say 5 mLs for every 20 pounds. It's 22 pounds, but it's close enough. These are not rocket science maths. Yeah. So you might as well make it the math easy for yourself and also for the people you're advising when they go home.
Yeah, and that makes it really easy when you're doing discharge instructions or when you're right in the room. You really don't have to get the calculator out for acetaminophen and ibuprofen if you know that little trick.
Yeah.
Yeah, very, very important.
Just to add to that, from homegoing standpoint, we do a lot of anticipatory guidance of, we want your kid's pain to be managed at home. This is also a skill to practice and learn, because we want you to grow up to be an adult who's able to manage pain using behavioral strategies before having to go to the next level, especially with the opioid crisis.
Yeah.
So we're talking a lot about, here are some non-pharm things you can do at home and kind of recreate from what we've been doing here at home first, as well with the medication that's been encouraged and recommended.
Yeah, absolutely. And just really continuing what you guys are doing in the emergency department, empowering parents to continue to do that in the home environment can make a big, big difference.
Absolutely.
Too. Yeah. One other thing as we think about pain in the emergency department, if I had to label the 2 most common things that really are going to impact a kid going home with pain, of course, broken bones and fractures are one, but dental pain is also very real. And I think the best, the more that we can get ahead of the pain, the better they're going to do at home, because they can't always get in to see a dentist right away.
Yes. So I think it's easy to underestimate dental pain. It's just the it's just the mouth. But I mean, a child's experience with the world, starting as an infant, pretty much begins with the mouth, and it's a pretty sensitive area. And ibuprofen works great for that too.
Yeah, it really does. And if you have to combine, if it's not working well by itself, add some acetaminophen, and the two of those together can knock out dental pain. And I've had tried that myself before, and it works really well.
And it works for migraines too. Acetaminophen and ibuprofen metabolized in different ways. They can be taken simultaneously.
Yeah, and have slightly different pathways. Yeah, exactly. All right. Well, I want to sort of end things with talking about Child Life Services, because we have a child life specialist with us, which we do not have very often. And we've talked a lot about what your role is in the emergency department, and we mentioned on other floors you do some other things. What does that look like, your job throughout the rest of the hospital?
Sure. So we are on most inpatient units. So a lot of times that is, like I said, we are doing medical play, helping provide education to kids about what is my diagnosis, especially on units where it's quite an intense treatment, like the hematology oncology floors, of why is my medicine making me feel more sick? That doesn't make sense. So we're finding creative ways to help explain that so that they can cope with the illness and all the other parts that come with treatment and hospitalization. But we're also doing a lot of sibling support. So we know that families do not just include who presents to the bedside. And we know that there's a lot of stressors that occur for other family members and other kids. And siblings are just as prone to misconception as the patient is. So if siblings are only hearing their brother or sister cry in the background when they're on the phone with mom to check in on how are things going at the hospital, that can feel really scary and confusing for siblings. So we make intentional efforts to involve siblings and educate families about appropriate ways to involve siblings. So we have something called the Sibling Clubhouse here at Nationwide Children's that is a special place that is specifically for siblings and is really a place that they can engage in therapeutic play with child life specialists, with volunteers, with our staff in the clubhouse who are able to promote their emotional safety. So we're in that inpatient, more of that acute care, but then we're also outpatient in a lot of medical specialty clinics, hospice, radiology. So kind of everywhere, always trying to expand and grow because we know that needs exist everywhere. We were really involved in our vaccine clinic when we had that here, knowing that there were a lot of kids coming in who shots are scary, but we knew it was so important for public health at that time. So we were doing a lot with promoting kids to be coming in and getting those by helping parents cope and helping those kids cope in the times that they're here. So we're kind of all over, and the umbrella is really dependent on the unit and situation going on. But at the core of it, we are really looking at emotional safety, making sure we're using developmentally appropriate language, that we're doing atraumatic care, that we're not re-traumatizing old traumas that patient may have, and really looking at all of the psychosocial factors that influence coping inpatient, but outpatient, and also in community-based settings.
Yeah, absolutely. A couple things came to mind as you were speaking. One, that dealing with the siblings and the family is also important, because we didn't mention this specifically, that their reactions can also feed into the patient's anxiety. So, if a sibling is really upset about a broken bone and about what's going to happen, and they're talking faster and they're anxious, they're worried, that can feed into the child who has the broken arm, making it feel worse. And of course, if a parent is also very anxious, the child's going to pick up on that. And so it's really important to help the siblings and the family, even from the patient perspective.
Absolutely. Patients will assess their sense of safety based on the adults and people around them. So if mom and dad look like a level we have never seen before and are panicking, they are going to think, this may not be a safe situation for me, and maybe I should be really scared and panicking too. That can occur with siblings. So that may look like us supporting a parent to be able to kind of get to a calmer state, or a sibling taking them to a different space if that's what's helpful for the patient and sibling. So it's really helping the patient cope by making sure that the sibling is being attested to, and same with the parents.
Yeah, yeah. And then the sibling playhouse or clubhouse that you had talked about, that was closed during the pandemic, but it's back open now, right?
It is, yes. Right now our hours are a little bit restricted, just getting staffing and our volunteer numbers back for working in the clubhouse. But yeah, that space is one that was very, very missed, especially by families of children with chronic illness, and the siblings. So the siblings, sometimes the hard part is getting them out of the sibling clubhouse because they're at the hospital, they get to play, they get to talk about their brother or sister, but it's all about them. So it was a very missed place during the pandemic, and we are excited that it's open and expanding hours and staffing so that we can support the whole family.
Yeah. And we'll put a link to Child Life Services at Nationwide Children's Hospital. So folks who want to learn more about what you do, they can find that over at PediaCastCME.org for this particular episode, the show notes for this one, episode 79. We'll put a link to that there for folks. And then DJ, tell us more about pediatric emergency medicine at Nationwide Children's Hospital.
So we have a very large emergency department, 62 beds, 6 triage beds, 68 beds. That's actually pretty huge. We have probably at this point 40 or so pediatric emergency medicine attendings and another 30 or so. I may not be exactly right about these numbers of general pediatricians who work in our quote unquote fast track and urgent cares. In fact, it might be a lot more than what I just said. We have a lot of people. We have a 3-year fellowship, and we have done a really good job of interweaving our scholarly and clinical operations enterprises. So we do a little bit of a lot of everything.
Yeah. And really looking at it from not only clinical care, but as you said, research and advocacy and community education. And of course, me also being a member of emergency medicine, we put out a podcast for folks.
Well, we do a lot of outreach.
Yeah, absolutely. And we also have an off-site emergency department as well up in Lewis Center. So folks up in the northern part of Central Ohio, you kind of have a closer acute care facility.
Yeah, it's actually it's a freestanding pediatric emergency department. Yeah. It's not that many of those around. I think it serves that region very well. It was a stressor, but an interesting kind of challenge for us to take that on, and we're glad that we do it. I'm actually one of the physicians who works both on main campus and Lewis Center, and I really enjoy having the different venues.
Yeah, absolutely. We're going to put lots of links in the show notes for folks, again, over at PediaCastCME.org. I had mentioned before that this particular episode is a joint venture between Nationwide Children's Hospital and the Emergency Medical Services for Children Innovation and Improvement Center. And I'm going to put a link to the EMSC Innovation and Improvement Center, as well as links to pediatric emergency medicine at our hospital, Child Life Services at our hospital. I had mentioned the Association of Child Life Specialists. And then this particular episode is actually packaged together as a pediatric pain series. And I'm going to put a link to the other podcasts that are available to you if you'd like to learn more about pediatric pain from various lenses and angles. And there's also a pediatric education and advocacy kit known as PEAK on pediatric pain. And I'll put a link to that in the show notes as well. So as we wrap up, I just want to say thanks once again to Dr. DJ Scherzer and Courtney Hall, both with Nationwide Children's Hospital. Thank you both so much for sharing your expertise with us today.
Thank you.
Thanks for having us.
Yeah. Thanks for helping us manage our public speaking anxiety.
Oh, absolutely. My pleasure. We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thanks to our guests this week, Dr. DJ Scherzer with Pediatric Emergency Medicine at Nationwide Children's and Courtney Hall, Child Life Specialist at Nationwide Children's Hospital. A quick reminder regarding this particular episode of PediaCast CME. This has been a co-production from Nationwide Children's Hospital and the Emergency Medical Services for Children Innovation and Improvement Center, whose mission is to minimize morbidity and mortality of acutely ill and injured children across the emergency continuum. To learn more about the Emergency Medical Services for Children Innovation and Improvement Center, you can visit their website at emscimprovement.center, and I will include a link to that site in the show notes for this episode, number 79, over at PediaCastCME.org. Don't forget, you can find us wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You will find our entire archive of past programs there, along with show notes, CME information, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. So you listen to the podcast. Now be sure to claim your free Category 1 Continuing Medical Education credit. It's an easy thing to do. Simply head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. Super easy, right? And again, we offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Of course, you'll want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. Also want to remind you about plain PediaCast without CME. It's our evidence-based podcast for moms and dads. Lots of pediatricians and other providers also tune in as we cover pediatric news, answer listener questions, and interview pediatric and parenting experts. Shows are available at the landing site for that program, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.